prepping to go. We're going to be ready to start in less than a minute. Okay, so I believe we're live. Good evening, everyone. Welcome to Medical Mondays with Dr. O. I'm Dr. Toyin Okwesomi, a family practitioner, HIV specialist, and I treat addictions in Maryland in private practice. I'm always excited to be here every week to learn something new from our speakers. And I'm so excited tonight. I'm thankful to Dr. Famuyiwa for introducing me to Dr. Omolara Olowoyeye, our very own dermatologist who will be presenting to us tonight. For all of you on this forum, you know that getting a dermatologist in this time and day who also is on the cutting edge of technology is difficult. Appointments are like 100 yards away, but not with this amazing doctor. And when Dr. Famuyiwa found her, she said, oh, you're coming to Medical Mondays, you're coming to bless us. And here she is. So I'm going to actually yield to Dr. Olowoyeye and have you complete your introduction. Welcome to Medical Mondays with Dr. O.
Thank you so much for that introduction, Dr. O. I also have my patients call me Dr. O as well. So there's two Dr. O's here, I'm sure many more. But thank you very much for that wonderful introduction. My name is Dr. Omolara Olowoyeye, as she's mentioned. I am a board certified dermatologist. I did my undergraduate education at Dartmouth College. It's an Ivy League institution in New Hampshire. After that, I got my Master's of Public Health at Nova Southeastern University. It was in South Florida. And then I always say I'm a Marylander ever since. I went to GW for medical school. And then after that, I finished my residency training at Johns Hopkins University in Baltimore. So now I am based in Bethesda, Maryland, which is about 30 minutes north of Washington, D.C. Within the last 2 years, I opened my own dermatology practice, and I am more than excited to present to you all about eczema. So without further ado, let's get started. And thank you to Dr. O for bringing me on board for this wonderful opportunity. Okay. So let's start with eczema. So basically, eczema is a generic term for a group of conditions that cause skin inflammation. And as a group, they may include contact dermatitis, dyshidrotic eczema, neurodermatitis. And specifically, we're going to focus this talk on atopic dermatitis. And if we have time, we'll touch on nummular eczema. So you may hear the term eczema being thrown around, but it's really an umbrella term for a lot of different dermatitis, as we call it. And specifically, we'll focus on atopic dermatitis for the sake of time. So the goals and objectives of this discussion is to develop a clinical approach to the evaluation and initial management of patients with atopic dermatitis specifically. Again, we may touch on other dermatitis. At the conclusion of the discussion, the audience will be able to do the following: identify and describe the morphology of atopic dermatitis, recognize the role of secondary infections in atopic dermatitis, recommend an initial treatment plan for a child with atopic dermatitis, provide patient and parent education about skincare for a child with atopic dermatitis, determine when to refer a patient with atopic dermatitis specifically to a dermatologist. And so let's get started on a case-based exam. In dermatology residents, we are always trained on case-based kind of evaluation of patients. So I think that was a good way to kind of approach this. So case one, the history is as follows. Caroline is a 10-month-old girl who was brought to her pediatrician by her mother for an itchy red rash for the last 7 months. The rash waxed and wanes, involving Caroline's face. Her mother reports Caroline is bathed daily using quote unquote normal soap. Sometimes they use moisturizing lotion if her skin appears dry. They recently introduced peas into her diet and wonder whether it may be contributing to her rash. So the past medical history is as follows. Normal birth history. She was healthy aside from an episode of wheezing at 5 months of age. No hospitalizations, no surgeries, no allergies, no medications. In terms of family history, the mother does have asthma and allergic rhinitis. They live in a house with the parents, no pets, no recent travel, but the review system did show that she scratches all night. So the question for the audience would be, how would you describe Caroline's skin rash? And just from, kind of being in the audience of previous Medical Mondays, I'll just kind of give you a little second to think about it and then kind of go up and proceed with the talk. So I'm seeing here the rash, it jumps out at me on the cheeks, but specifically what we kind of see as outliers is a sparing of this nasolabial fold and maybe some involvement of the neck. So the preferred answer is that you would describe this rash as an erythematous, ill-defined plaques with overlying scale, serum crust, and erosions on the bilateral cheeks, maybe adding to the fact that it spares the nasolabial folds and the nose. So based on her history and clinical findings, she is diagnosed with atopic dermatitis. So what is atopic dermatitis specifically? Atopic dermatitis is a chronic pruritic inflammatory skin condition with a wide range of severity. Atopic dermatitis is one of the most common skin disorders in developed countries, affecting approximately 20% of children and 4 to 10% of adults. The majority of children with atopic dermatitis are diagnosed and managed by primary care providers. First line of treatment for these patients, and very important first line. The onset is most common between ages 3 to 6 months, and with 90% of the children diagnosed by age 5. So it's important to know that up to 30% of the patients will have the disease persist into adulthood, but an opposite, more optimistic way to think about it is that well over 50% of these patients will outgrow their atopic dermatitis, which can be very reassuring because this is a very distressing condition, especially to the parents, most especially to the children that are going through it. It is important as a skin of color dermatologist to really highlight healthcare disparities when we do see it. And atopic dermatitis and skin of color is very important to highlight that there are healthcare disparities, in fact. Black children are 50% more likely to have atopic dermatitis than white children. The onset is usually earlier. The disease severity is usually worse, and the condition usually persists longer in Black children. And we do know from clinical data that there are higher inflammatory markers in Black patients, such as ESR, CRP, eosinophils, and ferritin. So as a collective, I am on the board of the medical education for the American Academy of Dermatology. And one of the things that we really try to highlight is highlighting healthcare disparities when we see it in medicine. And this is an example of one. So atopic dermatitis patients will present with itching. Usually it's not just a rash that you see, and it can be often described as an itch that rashes. Patients can describe really, really intense itching, and they really, really scratch. And this scratching and this and the rash subsequently can be very, very debilitating, not only to the patients, but also to caretakers, parents. And we talk about the loss of sleep and deep sleep for patients that are itching throughout the night, for example. We know that growth hormones are, involved during deep sleep, and that's important for children's growth cycles. And when you have patients that are itching and scratching throughout the night, are not getting those deep REM sleep, this can be, more than just what you see, cutaneously. It can be really affecting psychosocial development, physical development, and even interactions and family dynamics. So scratching is really common to relieve the atopic dermatitis associated itch that gives rise to this itch scratch cycle. And then that subsequently then exacerbates the disease. So we always talk about what comes first. Is it the scratching or the itch? And one begets the other, and so on and so forth. And at Johns Hopkins, we actually had a behavioral health liaison that would work with the pediatric dermatology clinic and helping patients kind of stop this itch scratch cycle, because a lot of it does become behavioral too, in the sense that we know that it's very itchy, it's a very debilitating condition. However, in a lot of pediatric patients, they will kind of develop certain behavioral mechanisms to itch more. For example, they know they can be more parents could be more sympathetic when they itch, so they scratch, to get their way sometimes, or they, when they're stressed, they tend to itch. When they have, different triggers, they tend to itch. So we try to treat cutaneous involvement, but also break this like behavioral cycle that often gets exacerbated as well with the actual skin condition. So lesions are, as we described, erythematous and scaly. They can also display vesiculation, oozing, crusting. More chronic lesions can become more what we call lichenified. Lichenification refers to the epidermal thickening or accentuation of skin lines. So we often refer to this as elephant-like skin. It becomes very thick with lots of lines in between, and that kind of refers to and shows and indicates that there's been long-standing itch and scratching going on, and therefore worsening disease. Again, the distribution can vary with age and severity. So these are typical atopic dermatitis presentations in infants and in toddlers. As you can tell, it can affect different areas of the extremities. It's important to note in really, really young infants, if you notice, just in Caroline's case, they have a lot of cheek involvement. And why is that? Because they don't have the dexterity to kind of scratch themselves actually, or maybe they're using mittens or gloves, or parents have that kind of intuition to kind of minimize that. So they're often rubbing. So that's one of the first signs in infants, is just constantly rubbing the breast while breastfeeding, rubbing against clothing, rubbing against their cribs. So it's really important to kind of find these early markers of atopic dermatitis, especially in young kids that don't have the dexterity to start scratching and causing the lichenification. Also can involve the scalp, the forehead, cheeks, extensor surfaces, as in those photographs. More examples of atopic dermatitis involving the face and the extensor regions. And in older patients, you see the more pathognomonic indications of the involvement in flexural areas. So we always look at the antecubital fossa and behind the knees. So you always want to check for flexural areas of the neck, elbows, knees, wrists, ankles. So as we mentioned earlier, eczema is a nonspecific term that refers to a group of inflammatory skin conditions. It's characterized by pruritus, erythema, scale. It's atopic dermatitis specifically is a type of eczematous dermatitis under that umbrella. And the cause can be very multifactorial. It's not completely understood, but we think the factors that come into play include genetic predisposition. We already talked about the healthcare disparities for that. Skin barrier dysfunction, which we'll kind of get a visual kind of clue about in a second. Immune dysregulation and environmental factors, whether it be fragrances or allergens, etc. So this is a pictorial kind of diagram of what normal skin looks like. You have a strong skin barrier here where you have really good, what we call stratum corneum, which is the top layer of the epidermis. And here you'll find that these epithelial cells, these circular kind of circles here that kind of depict the epithelial cells, are bonded by filaggrin, okay? Filaggrin, you can think of as the glue that sticks the epithelial cells together, and that creates your stratum corneum and therefore your top layer of skin, which is called the epidermis. And then deeper, you'll find lipid cells. You have a natural moisturizing factor because you have this intact barrier. Again, the filaggrin is causing this great bonding in between the epithelial cells. So the keratinocytes are basically bonded and intact, and you have a great strong barrier because of this. Barrier to allergens and irritants. And we all know from medical school that, the skin is the largest organ of your body. So it's a first barrier to any kind of infections, irritants, allergens. However, in eczema, you have a weakened skin barrier. And so I always describe to patients that the glue that holds these epithelial cells together are genetically not, intact. So you can see filaggrin here and here are not keeping this, these epithelial cells together, the proverbial glue that holds the stratum corneum together. So you have a breakdown in the skin barrier, penetration of allergens and irritants. You have more transepidermal water loss, therefore dryness, and fewer lipid cells and less moisturizing factor. So that's a simplistic level to kind of look at. But we know from our medical training that it's really more detailed. When you have a disruption of the epithelial kind of cells and the stratum corneum, you then have allergens and viruses that then trigger Langerhans cells. So these are the immunologic cells, and they're the first kind of, step in a very complicated cascade where the Langerhans cells then present to dendritic cells and release IL-24, IL-33, different interleukins that then propagate the Th2 immunologic pathway. And sometimes the B cell cells are being propagated as well. So then you have propagation of IgE and many, many interleukins. This is very important because the target of these new immune modulating medications, biologics, if you will, target a lot of these interleukins downstream this inflammatory cascade. So what does that mean? With atopic dermatitis, you have, as an overview, recap, decreased skin barrier abnormalities, decreased filaggrin, decreased ceramides, decreased antimicrobial peptides. And that's going to be important when we talk about treatment. I always tell patients that, when you have atopic dermatitis or your child does, you naturally have decreased antimicrobial peptides that destroy bacteria. So atopic dermatitis children have naturally, or eczema patients have naturally more bacteria on their skin than normal patients. And that's really important when we start talking about treatments. So this then increases serum proteases and overall increased immune dysfunction. So back to Caroline. So what would be the most appropriate topical steroid, which is the first line of treatment for atopic dermatitis in children? Would it be clobetasol, 0.05% ointment, fluocinolone, 0.05 ointment, hydrocortisone, 2.5% cream, or the ointment equivalent of that? Or would you pick triamcinolone? I'll give you a second to think about that. So the correct answer would be hydrocortisone ointment, and you want to pick the least potent topical steroid that is going to be the most effective, and we'll talk about why. So you want to look at topical steroids as a class. Look at the class, not the percentage. So clobetasol is top class of topical steroids. So it's stronger than a class 6 hydrocortisone 1%. And there's potency charts that you can find online or Google, but I'll include a simplistic one here in the next slide. But when topical steroids are listed, they're listed in order of strength. So class 1 is the strongest strength, class 6, 7 is the least potent strength. So for example, you can find hydrocortisone 1% over the counter, for example, is the least potent topical steroid there is. So as you can imagine, that's really not going to do much for this type of skin inflammation. And you also need to know about vehicles. So ointments are stronger vehicles than creams. Think of the way we were taught vehicles is that ointments are about mostly oil in content, whereas creams are 50% oil, 50% solution. Solutions are solutions, and lotions are about maybe 20% solution in nature. So ointments actually sit on that stratum corneum and they penetrate and are more effective than creams. However, there's a cultural kind of aversion to ointments in a lot of my patients. So it's really kind of like taking into the patient's, compliance, but ointments are more effective. So this is a very simplistic chart of potency chart for topical steroids. Again, class 1 is the strongest. Clobetasol is the most we have. Then fluocinolone, for example, is class 2. Triamcinolone is what you probably use often in as primary care physicians or specialists. That's commonly used. It's a medium potency. And then hydrocortisone 1% is, in the low potency category. But a very detailed chart can be available, like can be pulled online. So again, back to Caroline, she's developed atopic dermatitis now on her extremities, and she's using hydrocortisone 2.5% ointment twice a day for 4 weeks with minimal improvement. What do you think her next step will be in terms of management as her physician? Do we want to increase the frequency of the ointment to 3 times a day? Do we want to increase to triamcinolone twice a day? Do we want to mix the steroid with petrolatum, or increase or start our calcium and calcineurin inhibitor, or use a phosphodiesterase inhibitor? So the correct answer is increase the potency to triamcinolone. So in this case, we're going from a class 6, 7 potency to a class 3. So you're kind of bumping her up in nature. And specifically in my practice, I usually like taking breaks with topical steroids. So I'll go twice a day for 2 weeks and then take 1 week off and then repeat as needed. Being very mindful of how much I prescribe and how many refills I give. Because we do know that, side effects of topical steroids include atrophy, skin discoloration, where there'd be hypo or hyperpigmentation. So topical steroids are safe when used in short intervals with intermittent rest periods. You want to avoid the side effects because they can occur when used for extended periods of time. And if symptoms are not improving despite adequate trial of low potency topical steroids, you can increase the potency, maybe only to the mid potency only. I wouldn't go beyond that, just to treat the acute inflammation and then slowly taper off. And these are really kind of, elemental first approaches to dealing with this. Medium and higher potency topical steroids must be used with caution. I would say not at all in children, but maybe using caution in older children or adults. And then the highest class 3 steroids, class 1 steroids, the clobetasol, I usually avoid altogether, especially in high-risk areas like the face, the folds, the groin, and in diaper areas. So Caroline's parents also want additional information about the association with food allergies in atopic dermatitis. I'm sure that's a very common question that you, as physicians that encounter this, get a lot. So what would you tell them? Would you say that a positive allergen test proves that allergy is clinically relevant to her skin condition? Food allergies is a known trigger in 20 to 30% of patients with moderate to severe atopic dermatitis. Most common cutaneous manifestations of IgE-mediated food allergies. Most common cutaneous manifestation of IgE-mediated food allergy is atopic dermatitis. You recommend to strictly eliminate any foods that they suspect is related to her atopic dermatitis, or there's no correlation between atopic dermatitis and food allergies. I know I kind of read that really fast, but I'll give you a second to read it yourself. And so the correct association between food allergies and atopic dermatitis is that food allergies is actually well known to be common trigger in 20 to 30% of patients with moderate to severe atopic dermatitis. We don't recommend a full elimination of their suspected foods, but you do want to kind of try to find have the parents put down a food diary, for example, and really kind of track that over time. But kids are growing. You don't want to start eliminating things left, right, and center unless there's really a true direct causality. So IgE-mediated food allergies also have been known to worsen atopic dermatitis after exposure of food, but additional symptoms such as urticaria, angioedema, difficulty breathing, vomiting, diarrhea can also occur. So you want to definitely track those symptoms as well. They can also have protein-induced allergic proctocolitis, especially association with bloody stool. So when there are direct causalities, we start slowly eliminating certain foods from the diet. Sometimes exclusion diets, very severe exclusion diets can lead to a loss of food tolerance and increase the risk of immediate type reaction. So you really want to work with an allergist to really kind of find the direct causalities and also with the pediatricians to determine which foods to slowly eliminate over time, if not all. So another question that they had as parents was if her atopic dermatitis predisposes her to other medical conditions. So which one would you counsel the patient's parents about? Is it that the risk, she's at risk for allergic rhinitis, but no other allergic disorders? Is she at risk for asthma and no other allergic disorders? Is she at risk of food allergy and no other allergic disorders? Or is she at risk for allergic disorders, food allergies, and allergic rhinitis, or there is no correlation whatsoever with other medical conditions? So the correct association with atopic dermatitis and these other medical conditions is that you are at an increased risk for food allergies, allergic rhinitis, and allergic disorders when patients present with atopic dermatitis. So we refer to this as an atopic march. It's the progression of atopic dermatitis in early infancy to other allergic diseases such as food allergies, allergic rhinitis, and asthma. We think of it as a triad in a sense. There must be some kind of common gene where all of these must present, because the commonalities of all in patients with atopic dermatitis is so significant. The onset and its severity are influential in the progression of each individual condition. And there's a lot of studies looking into these what interventions can be done to halt the progression. So we do find that if patients do have atopic dermatitis. The only caveat is that, yes, they are at higher risk of asthma and seasonal allergies and food allergies. But if you treat one, and that doesn't necessarily mean that their eczema will improve, or if their asthma is being well treated, it doesn't mean that their skin is going to improve. So there's not a direct causality when it comes to the treatment of one affecting the clinical progression of the other. So another case is Ben. Ben is a 3-year-old. He's referred to dermatology clinic for atopic dermatitis. We already know he has this condition. He's using hydrocortisone 2.5% ointment without noticeable improvement for 14 days, however. And so we do know he has atopic dermatitis, no allergies. He's on the hydrocortisone. His older sister has eczema. He lives with his parents. He attends preschools, no fevers. But then he presents with this. And so how would you describe this presentation on his feet? I'll give you some time to think about it. And so I would describe this as lichenified, again, those like elephant-like thick skin, erythematous plaques with overlying scale, fissuring, and hemorrhagic and brown crust. So what is the next step in the evaluation of Ben's atopic dermatitis? Do we apply a potent topical steroid, obtain a skin culture, apply topical antibiotics, or perform a skin biopsy, which we often do in dermatology? So when patients are presenting with this kind of presentation, you want to see that it's, these crusts over can be very indicative of superficial infection. So you want to obtain a bacterial culture in the immediate next step of evaluation. So secondary infections are very common, and we already talked about why we have a downregulation of antimicrobial proteins in the skin of atopic dermatitis patients. The skin bacterial culture should be considered during acute weeping flares of atopic dermatitis when there's pustules, erosions, crusting, yellow, brown, or hemorrhagic crusts are present. Patients with atopic dermatitis are very highly susceptible to secondary infections such as Staphylococcus aureus and group A streptococcal infections. These infections thereby, cause prolonging, worsening flares, and sometimes systemic and topical antibiotics can be required. So this is an example of a very severe case of secondarily infected atopic dermatitis. You're looking for this yellowish serum crust over the underlying atopic dermatitis plaques. And so treatment, we want to focus on 4 major components. We want to treat the anti-inflammatory components. You want to treat the itching, so the antipyretic component. You want to moisturize because we know that the skin barrier is not intact anymore. And then we just talked about the antimicrobial aspects of this condition. So the anti-inflammatory, we talked about extensively with using topical steroids, the first line of treatment. Ointments are preferred vehicles over creams. You want to use a low potency topical steroids, I would say for the entire body for infants and toddlers. Maybe consider mid potency topical steroids for older kids, maybe above 10 or so. Sometimes, however, body extremities may require medium potency steroids. But in infants, I usually don't go higher than hydrocortisone 2.5 unless it's really severe. You want to use stronger steroids for short periods of time and milder steroids for maintenance to reduce the risk of skin atrophy and other side effects. And we know that potential side effects associated with topical steroids include stria, telangiectasias, which are superficial blood vessels, atrophy, which is thinning of the skin, and you can even get steroid-induced acne, which is very common. So antihistamines help break this itch scratch cycle. Okay, so we like using first generation antihistamines such as hydroxyzine. but it does come with some side effects of sedation. Sometimes I'll go with second generation antihistamines like Zyrtec, but usually not as helpful. But in older kids, maybe more preferable than the sedating antihistamines. And sometimes we'll use topical antipyretics, although it's just short term. So moisturizers are the hallmark of atopic dermatitis treatment. It's important part of the regimen, especially to help build back up that transepidermal loss, and also the breakdown of the barrier, the skin barrier. So it also reduces frequency and severity of flares. And we should be recommending safe, effective, inexpensive, fragrance-free, perfume-free moisturizers that won't be sensitizing to the patients. I like the greasier the better. So I have like a kind of stepwise approach to patients kind of dealing with their treating their eczema. And so at the top of my list is mixing your thick body moisturizers like Cetaphil, CeraVe, Vanicream, Vino Baby with Aquaphor or Vaseline, really just to kind of seal in that hydration. And it's also good because they have less preservatives and they can be very occlusive. So bathing, it's very controversial, especially in the age of social media. Celebrity will talk about how they only bathe their kids like once a week, and it becomes an uproar. My approach to bathing is it can be very culturally sensitive. Some cultures, it's just blasphemous to counsel them to bathe their child twice a week or every other day. So from a dermatologist standpoint, every other day is ideal for a patient that has atopic dermatitis, because you are stripping the body's oil and you're disrupting the skin barrier. But if there's a cultural kind of association with bathing every day, I would say just don't scrub. Make sure you're hydrating and moisturizing immediately after and leaving some water on the skin. So you really want to apply those moisturizers immediately after bathing. Limit the amount of bathing and use lukewarm or cold showers. Limit the use of soaps if you can. If you do, use hypoallergic soaps, and then bleach baths. It's always interesting how parents look at me when I mention this. It's like, do what? Again, going back to the pathophysiology of atopic dermatitis, we know there's a downregulation of skin antimicrobial proteins. So you have more bacteria on the skin, so you want to decrease that burden so you're not flaring as much. And just dipping those kids in a diluted hypochlorite solution really can be helpful. And the way I kind of counsel parents is it's almost the equivalent of letting them swim in the public swimming pool. They use bleach, as an antimicrobial chemical. So you're kind of recreating pool water. So you basically take 6% regular household bleach, Clorox bleach, and you dilute it as such. You can do half a cup in a full bath, 1/4 cup in half a bath, or 1 to 2 capfuls, which is the cap that comes in the actual Clorox bleach, in a baby's bath, and just soak them in twice a day for 10 minutes. Really can be helpful and a game changer for atopic dermatitis patients, especially the moderate to severe patients. So when to refer to a dermatologist? When they have recurrent skin infections and when they have extensive severe disease, when symptoms are poorly controlled with topical therapy. And just to brief on the systemic therapy, we as dermatologists escalate treatment when there's inadequate control despite optimized topical care, and when there's significant negative physical or psychosocial impact. So I like to add calcineurin inhibitors or light therapy if there's ability to do so, but it can be cost prohibitive, and not a lot of dermatologists carry narrowband UVB And we used to have to resort to immunosuppressive medications like cyclosporin, Celsep, methotrexate, and azathioprine. However, we now have systemic therapy, and this has been a game changer for us in dermatology, especially since I graduated residency. I mean, the advent of all these biologics has really changed the landscape of treating atopic dermatitis. So the first biologic drug, dupilumab, which is Dupixent, was approved in 2017. It's FDA approved for patients 6 months and older, and it targets the IL-4 and the IL-3 interleukins, which I showed earlier in the inflammatory cascade. And so just recently, last year, we now have Opzelura, which is ruxolitinib. It's a topical JAK inhibitor that is FDA approved for patients 12 and over for mild to moderate atopic dermatitis. And you've recently got, if you're interested, indications for vitiligo as well. So there's a lot of other biologics that are in phase 2 and 3 clinical trials recently. Like Arbery is one of them. I'm very excited to learn more about that at our Academy meeting coming up in March. But they're not FDA approved yet, but they're game changers. I believe that one is going to be FDA approved for children 2 years and above. So I'm going to quickly blitz through the rest of the presentation just to show you a little bit about different other additional clinical presentations of eczema. We talked about atopic dermatitis, which is under the umbrella of eczema, but in general, if you aren't preview to treating just children, you can see other cases as well. And I'll just kind of, for the sake of time, so we can answer questions, kind of go directly into the case presentation. This is a 9-year-old with spots on the face. And so the spots look like this. A lot of patients will come in, the parents will be very, very exasperated by this, thinking it's the Michael Jackson disease is what I say, what I call it. And it's not vitiligo, it's pityriasis alba, which is a low-grade, hypopigmented, patchy rash with fine scale. And pityriasis alba is a mild asymptomatic form of atopic dermatitis. I see it most oftenly on the face, but it can also present in the arms and legs. As you can tell, it's more common in darker skin patients. It's more evident in those patients as well. And there's a stark contrast between a tan skin and the pityriasis alba. But again, it's just low-grade eczema. We treat it the same. We reassure parents and patients that this is something that can be easily treated and it's not the Michael Jackson disease. So moisturizers and the same approach with atopic dermatitis. And we're switching now to adults. This is an adult that presents with a 3-month rash on the arms and legs. It presents as this, more circular, erythematous, flaccid plaques. A little bit of crusting on top, but they're annular, okay? They're not in the same distribution as the child. As you can tell, as an adult, lots of axillary hair. This is the legs as well. Some persons may even think this is psoriasis, but essentially, or tinea corporis, which is ringworm, but the KOH was negative. And they're round eczematous plaques on the arms, legs, and back. So this patient has nummular eczema. Nummular eczema presents as coin-shaped. Nummular is the Latin word for coin or round. They're coin-shaped eczematous plaques on the extremities and trunk. It lacks a central clearing. So usually that is a buzzword for ringworm when there's a central clearing. KOH was negative, and it's very itchy. So when someone presents with ringworm, they're not going to be itchy. Eczema is itchy. It's the itch that rashes. So this patient also, nummular eczema can also present with weeping, cracking, vesicles, and crusts. And the biopsy is very pathognomonic for spongiotic dermatitis. So just wanted to show you a different kind of presence. We all know, you know, just as we saw atopic dermatitis in children, it can present similarly with that same morphology in adults, but this is a very distinct form of eczema in adults. It's another kind of present example of different types of nummular eczema. This one is secondarily infected, as we learned, because it's weeping with the weeping discharge. This one is also secondarily infected. And so the way we would treat it is with a topical steroid. We would pick a mid-potency topical steroid like fluosinamide ointment. And then, you know, if it's not improved, go to something higher. So for the sake of time, I'll just review all different photos of what you can see in clinic for atopic dermatitis or eczema. And then we'll go into questions, or there's an overview and then we'll go into questions. These are all photos I think we've already seen. I just wanted to kind of refresh our memory. So take home points, atopic dermatitis is a chronic pruritic inflammatory skin condition, the wide range of severity. It's one of the most common skin disorders in developing countries. It affects 20% of children, 4 to 10% of adults. The distribution of skin lesions vary per age. Children with atopic dermatitis are at risk of developing a food allergy, asthma, and/or allergic rhinitis. The pathogenesis of atopic dermatitis is multifactorial. We're still trying to tease it all out, but does include genetics, skin barrier dysfunction, immune dysregulation, and the environment. The treatment includes long-term use of emollients, gentle skincare, as well as short-term treatment for acute flares, and may include topical steroids, but dermatologists can escalate the treatment to calcineurin inhibitors, sometimes oral and immune modulating medications, depending on the patient and the presentation. But we as a collective are kind of moving and bypassing all of that and moving towards biologics, because it melts eczema away and it's become a huge player in treatment. Antihistamines also help with pruritus and sleep issues. Again, children need that deep REM sleep so that those growth hormones, those growth factors can kind of be released, and so they can grow and be healthy. And if they're not getting sleep and itching all night, you can see how debilitating it is. Parents also lose REM sleep. You know, they're up all night with those kids too. So it can be very an intrusion, both physically and psychosocially as well. You want to monitor for secondary skin infections, treat accordingly, identify food allergies, and really should be reserved for, you know, atopic dermatitis patients that are not really improving and have a high suspicion for this food allergies with journaling or, you know, severe symptoms. Pityriasis alba is a form of atopic dermatitis on the face or in extremities in children. Again, counsel, they want to hear it. You know, you just kind of break the ice. It's not the Michael Jackson skin disease. And then you see like the wave of just, you know, relief come over the parents. You want to use emollients, sun protection for P. alba, and reassure the patients and the parents that it'll fade with time. And that's it.
Wow. Thank you.
You're quite
Thank you. That was so refreshing. I mean,
I echo that. Wow.
I hope it wasn't too much.
Thank you, sir. And he echoed it all the way from California, by the way. So thank you. I have some questions. So you can put this slide down so that it helps me to be able to, you know,
Stop
see.
sharing, right?
Yeah, stop sharing.
Okay, thank you.
Thank you. So in the chat box, there's a question there at least, but I have a question.
Yes.
I want to cheat. So the vitiligo, you talked
Yeah.
about the ruxolitinib. It's a new treatment. Does it reverse it, or does it restore the skin pigments back to norm, or it just stops it where it stops the vitiligo where it had affected?
That's a great question. So it's a brand new medication. I haven't seen the clinical manifestations of efficacy in clinic just yet. However, the clinical trials show repigmentation of areas of vitiligo. So they did studies on, I believe it was like clinically evident areas like face, arms, legs, and you did see repigmentation, not just stopping the progression. So we know that the stem cells are perifollicular, they're around hair follicles. That's where your melanocytes are from, or populate. Melanocytes are the pigment producing cells. So interestingly, as an aside, skin color, it's a fascinating topic for me, but we are all born with the same number or the same quantity of melanocytes. Okay. So my skin versus, a Caucasian person's skin, we have the same amount of melanocytes. It's just that my melanocytes produce more pigment and in different sizes than someone else. So that's an interesting aside, but those melanocytes are usually around hair follicles. So with Opzelura, you're getting repigmentation, usually perifollicular, usually around the hair follicles, but yes, you are seeing new pigment.
You know what? You just said something so profound. And a lot of us need to change our language, because we commonly say, our Caucasian counterparts don't have melanin. That's why, we have melanin, we're dark, we can absorb vitamin D from the sun like they will, and all of that. That is actually not a true statement. They have melanin. Of course,
So we're all white.
Yes, ma'am.
We have the same amount of melanocytes, the cells that produce pigment. It's just the amount and the quantity that may vary. And pheomelanin is actually specifically created by redheads. So they even have a distinct type of melanin themselves, but we're all the same at the end of the day. Just different flavors of the same thing. Yes.
So we need to change that.
Yes. And on a different kind of tangent in terms of skin color and skin differentiation, Black people get skin cancer. Okay. So yes, we need to wear the sunscreen. I just had a patient last week. I wasn't thinking about it. I would have had his picture up, and I asked him for a medical consent because he came for keloids. And I always try to convince everyone to get undressed for a full body skin exam. So I convinced him. He'd been at this, he was an African-American gentleman, really nice, in his 50s. He played baseball all his life as minor league. So he had a very interesting history, but he was out in the sun, big majority of his youth. And so when I did his skin exam, there was one black area right above his navel that I just had to sample. It just looked odd, and it was a skin cancer. So Black folks get skin cancer. Get your skin checked every year. It's very important. And statistically, when we do find skin cancers and skin of color, it's always end stage. It's always at high stages, very highly preventable. So yes, the likelihood of Black folks getting skin cancer is lower than lighter skin types, but it's still there as a risk. And why not? When we're talking about preventative maintenance, why not just add it to your preventative maintenance exams every year?
That is so true. I've got to tell you a story. I can't help it. So I went to Phuket in Thailand with my husband, and it was hot. And he was smart, he didn't go out into the sun a lot. Oh, did I not? I was in the pool, and I don't swim, by the way, but I had my swimming trunk on, and I would, just go in there and waddle and do whatever.
Mhm.
I was in the sun a
Mhm.
lot. I came back with sunburn
Oh, yeah.
for the first
Easily.
time in my life, in my 50s then. And I was like, wait a minute, I've never been sunburned. I was born in Nigeria. I never been sunburned.
Yeah.
So one of my dermatology friends started laughing and said, so you didn't know you should put on your sunscreen? I never used sunscreen in my life. I never needed sunscreen. He said, oh, false. So I changed my language. I didn't learn that in medical school, that I needed sunscreen.
Healthcare disparity. Yeah.
I didn't. So I
did,
changed my language and, started encouraging everyone to put on sunscreen if you have to be out there in the sun, because even though you have more, or you have those special cells of melanocytes that I just learned, we can still burn. And yes, Black people do get.
And that's DNA damage. The DNA damage repetitively equals cancer. So we
Exactly. When it's repetitive.
Exactly. And we also, as skin of color patients, Black patients, genetically get a worse type of skin cancer that affects the nails, called acrolentiginous melanoma. And that's how Bob Marley died. He died from acrolentiginous melanoma. He had a black streak on his toenail, and then it started spreading, and then his toenail fell off. And so he went to the doctor. They wanted to amputate. He said, it's the man. The man is trying to take my foot. I'm not going to let the man take my foot. The story goes, we don't know, for sure. This is, celebrity gossip, but he did, the story goes, he denied amputation, and he died from metastatic melanoma. So skin of color patients, Black patients statistically get acrolentiginous melanomas, which is even a more, if not for your regular skin, you really need to be checking your nails and your hands and your feet with a board certified dermatologist every year. When these melanomas are found, they're usually found end stage. Another healthcare disparity. So another reason to see your dermatologist every year. I just saw mine, so everyone should.
So, we don't usually recommend that. I personally have presented here, things to do, doctors to see, what to do yearly. So what do we tell the insurance companies to come see you if we don't have specific issues, just for preventive care, so that a dermatologist can look at one all over? What do we tell the insurance company?
Oh yeah, very good question. Full body skin exam. It's a screening that gets reimbursed as often as you want. There's no limitations usually. I know there's certain preventative maintenance exams that can only be reimbursed yearly, but not dermatologic skin exams. If patients want to come every 3 months because they're just more comfortable because of a family history or whatever, we have a discussion, we make sure it's medically appropriate, but there's usually no insurance limitation. So you ask if you're in a plan that requires referral, then you want to talk to your primary care doctor first and ask for a referral. If you have an open access plan, then just call a dermatologist and make an appointment for a full body skin exam.
And by the way, if you look at the chat box, I've posted Dr. Omolara Olowoyeye, Radiant Dermatology. She's in Bethesda, Maryland. And like I said before, when I introduced her, in case you were not here then, that she's one of those few dermatologists that we have now that are on the cutting edge. And I'm going to have her talk to us. I didn't tell her before about PRP.
Oh, yeah.
This talk, because personally, I was looking for someone to do this PRP on a patient, and no dermatologist that I know in Maryland does it. They actually have some standalone areas that do PRP, but they are not dermatologists, but she does. So who is best to do your PRP? She will tell us more about that later than your dermatologist. So stay tuned. I have a question here in the chat box by Dr. Jagwe. What are the common causes of contact dermatitis? That's the first question. Oh, I think it's asking if it's detergents, soaps, lotions, or perfumes, etc.
So I would say it varies per patient, but the Society of Atopic Dermatitis actually puts out the top 5 allergens every year. So there's always different allergens every year, but number 1, which is a dermatologist's pet peeve, is neosporin or neomycin, actually. So after biopsies, we always have patients use Vaseline and Vaseline only, and some of them just are rebellious against that. And they will put on their neosporin or neomycin, you know, the triple antibiotic. I know my mom swears by it. Anything that happens on her skin, she's putting it on. And it's usually on the top 5 allergy list every year. Why? Because most people develop some kind of sensitivity to the neomycin. So is it the number 1? No, but it's always in the top 5. And then comes none of the above. It would be adhesives. The acrylates usually are the top causes of contact dermatitis. You know, and it's very common in our, you know, sickly kind of patient population, patients that have diabetic supplies or open wounds, you know, post-procedural, we'll do biopsies, the wound will heal great, but then there's this rash all around it, adhesive contact allergy, or from medical tape or bandages from blood draw. So we see that very commonly. In the atopic dermatitis population, we see more fragrances as contact dermatitis, especially in fragrances and perfumes, especially in the least suspecting areas. You would think that, you know, very holistic or natural products don't have fragrances, but they do, you know, or you go to Whole Foods and you just pick something, you think it's going to be great for your skin, but it's not. So you really kind of want to use hypoallergic sensitive products when you're dealing with patients with, you know, that are in that atopic dermatitis category.
Fantastic. So people who raise their hands get preference over questions in the chat box, because we can always go to that. So Auntie Tawa has her hand raised, and I'm going to ask you, ma'am. Welcome, ma'am. So unmute and ask your question.
Good evening, everyone. Thank you very much, Dr. Olowoyeye.
Thank you.
My questions are 2 parts. I'm supposed to go and see my dermatologist on Thursday. But it's for a skin. I have this cyst that is on my face and it won't go away. So that is why I'm going. But is it possible that when I get there to ask for full body examination, or they will just say, you know, you are here for this?
I can only tell you how I practice, and I try to fit in full body skin exams because it's my way of looking at everything. And, you know, patients are going to be modest, you know, like, I'm so sorry I didn't get my nails done, or I didn't shave. You come as you are as a you know, to your dermatologist so they can see all your skin, is what I usually say, because it's really the surveillance that is the preventative aspect of care. So if in my practice, we allow, you know, 1 or 2 problems with the full body skin exams. When they start having the long list and, you know, the 7, 8 questions, we try to kind of maybe, you know, suggest another additional visit. But I think it's reasonable to ask, you know, and say, hey, I'm here for this, but I would love a full body skin exam. I just been at a talk by a Black dermatologist and she told me to get my skin checked. Okay. So if it's someone reasonable, I think, and professional, I think that shouldn't be an issue.
Thank you. The second part is I have a granddaughter that is a teenager, and her face is with acne. It's just horrendous. She is very conscious of it. They've taken her to dermatologists. They have some other thing. They have all this thing that they order, but it's not really helping.
How old is she?
She's 13.
Okay. So what I say is that, acne is very kind of complex, because you would think it's just one thing and one thing only, but can be 5 or 6 different individual etiologies. It can be hormonal, it can be bacterial, it can be epidermal, exfoliation, it could be all of the above. But let's just assume that she's had adequate treatment and has been compliant on a lot of the topicals. There's a stepwise approach, and I always say there's like 5 steps. You see me every 2 months, so we won't know, where you're at for at least a year. But let's just assume she's been through all those steps and nothing has worked. I always say that if I could put Accutane in water for teenagers, I would, if I could prevent them from getting pregnant. Now, we know that the medicine has significant side effects of birth defects, and so because of that, it's one of the only medications that the government oversees how we dispense and treat patients with. So you actually have to register through the iPledge.com program. The doctor has to certify every month. The patients have to certify every month. The pharmacists have to certify every month before the patients can get the medications. And then the patients have only 6 days to pick it up, 6 or 7 days. So with all those parameters in place, I would still put it in water, and the water filtration system, so teenagers can get it in their system and not have to deal with the debilitating effects of acne. So I have a very low threshold for Accutane treatment. It seems like that's probably what she would end up needing.
Our mom had acne, and our mom is a doctor, and she took Accutane. And honestly, I don't want our daughter to take it because there are some other side effects. That is, no. I don't think I will not agree even if she wants to do it. No.
Yeah. Well, we as dermatologists, we see kind of like the treatments of it, and some of those like mental health side effects are really over sensationalized. If you have a good dermatologist that can see the patients routinely and monitor, I think it's very, very effective with minimal long-term side effects, even short-term side effects as well, with good monitoring. But I wish her well.
Oh, thank you. My third question is skin grafting. Does it have to be particular color or tribe or anything when they do skin grafting for those people that got burnt?
Oh, okay. So with burn injuries, skin grafts usually are from self-donors. So it usually comes from like the same patient. There's now like biological like meshes that are from like bioengineered cellular material. Like they'll use a matrix of porcine, like pig skin and other things like that. But true skin grafting is from a particular site, usually thighs or extremities, for burn injuries. And so it doesn't necessarily have to be a specific area. Usually they try to get hair bearing areas, but it depends on where you're grafting as well, and what sites are available. Like if you have 80% involvement, burn injury, you have limited donor sites. So there's no real they're not picky in terms of where they try to get it from, but extremities are usually where they try to get the donor site from.
Thank you very much. I appreciate you.
Welcome.
Fantastic. So my last patient that I treated with Accutane, I used to treat before it became so rigorous to treat. It was incredible. I had to do pregnancy tests. She has to come in for pregnancy tests. It has to be a particular time before the medication is written. And by the time we were done, we cleared the acne. She did fantastic. Probably would never recall again. Had no side effects, but I
Yeah.
said that was it. So now it's for you
yeah.
guys. When I see patients with acne like that, we're like, oh, I'll give you a referral.
Oh, yeah. We have a very well-oiled machine, and it takes like a staff that knows the process. And now it's, they've revamped the system. I have this patient she's actually a Nigerian girl who I'm very happy to say is now in med school. She was my mentee. But she started as my patient, and her dad is a pharmacist, just like my mom's a pharmacist. I think one of our parents are always pharmacists somewhere, or doctors or lawyers, but I really had very intense conversations with the father about the reservations of Accutane. At that point, she didn't have any other options. And we kind of held his hand throughout, because he was as a pharmacist, as he should, or as a doctor, as he should be, highly skeptical and vigilant of potential side effects, etc. But she did well. And she started at Northwestern in the fall, with great, imagine the confidence and she always sends me pictures and things like that. So we have to kind of weigh the risk and benefits to everything too. But she did fine. Most of my patients do really, really well on the medication. But I really hold their hands, we're very strict, and we're very diligent with our patients. I think I've put through over 65 patients through the Accutane, the iPledge program, since residency, and I've been practicing now for 6 years now. And I may have had one complication where I had to stop, but it was a rare complication of systemic inflammatory syndrome. We just stopped and put the patient on steroids, but he had a very severe case.
And they do well after
They do
you stop.
really, really well. It's like night and day. It's amazing.
They do well. Even with that case you stop the medication, you treat, and they do well.
Oh, yeah. If you get to the gold dose, 95% of patients never have to deal with acne again. And that's great statistics. Like, you have to get to the cumulative dose. You have to get enough medicine in your system. But imagine 95% chance of never having to deal with something so debilitating. And I always caution in the age of social media, and social media and all of this front face, it's still odd to me. I'm not the most visually stimulated person. This is my first talk in many, many years. I'm glad to do it. But it's for the young kids. It's just, that's why I love dermatology, because it's amazing the confidence that you can instill in someone, because everything is just so visual now. And it never used to be like that for us growing up, but everything is just, your face is in front of everything in the world now. And it comes with a lot of psychological issues, suicidal concerns, and things like that nature. So I think that if we can take one thing off of their plate, why not? So
for this precious young one of ours that Antitawa is not comfortable with Accutane, and I understand when you have been through an adverse effect of a medication, you think twice, because it is what it is. So in a child like that, what about the cyclines like monocycline, doxycycline?
Yeah, so in the cyclines I like, they're kind of like the step before I jump to Accutane. The only thing is that in someone that young, it's not a good long term. I would be very cautious of the cyclines in 12, 13, 14, about 13, 12, that around that age group and younger, because it does stain the tops of the teeth. So tetracycline tops is how we learned it. So it can have like permanent bluish discoloration of the enamel. But that being said, I will use it in like 3-month intervals at a time until topicals take over. And so there's a stepwise approach to topical retinoids that I like for acne treatment. And if it's hormonal based, if it's, sometimes we'll do spironolactone, birth control. and a combination of other treatments.
Yeah, spironolactone. And,
Mhm.
I have tried the Neutrogena soap.
Yeah.
It's done wonders in some patients that said they've tried different things, and I tell them, stop everything.
Does it
They
have
don't make-
salicylic acid in it?
I don't know. I have to go look.
Yeah.
Next time, I'm going to check. I'm not sure. Neutrogena soap is like $2 something or $3 something.
Mhm.
The one in the red and white box.
Mhm.
I say stop everything and just use Neutrogena soap to wash your face in the morning and at night.
Yeah.
I have cleared so many just like that without
Young teenagers.
teenagers.
Yeah.
And I've tried it, with Doxy in adults.
Okay.
I
Okay,
don't
good.
use Doxy. I usually use
Yeah.
doxycycline. No,
Doxycycline.
minocycline. Yeah,
Oh
in
yeah, those are
older
great.
folks.
Those are
Yeah.
great. Young kids, I find that like between age 10, sometimes you'll get the precocious puberty induced acne from 10 to 14. They're not kind of in the routine of washing their face twice a day. And I kind of try to, a good analogy is, I try to like corner them and say, hey, do you ever think twice about brushing your teeth in the morning? And they'll be like, no, I just wake up and I go straight to the bathroom and I brush my teeth. I said, well, that needs to be your acne medicine. It needs to be like brushing your teeth. Get into the habit so you don't think twice about washing your face twice a day. But they usually haven't built up that habit yet. And so a lot of it is just exfoliation and skin cleansing. And then that usually helps kind of that wave.
So,
If it
Auntie
is
Sarah, maybe that's something to look for.
hormonal, then what do you do?
Spironolactone.
Spironolactone and birth control.
Yeah.
Yes.
And birth control.
Yeah.
And, thank you for bringing that up, because
Mhm.
a lot of African mothers and grandmothers who say, oh no, I don't want my child or my grandchild on contraceptive, because automatically they think it would make them start having sex. No.
Right, exactly.
No.
Yeah, there are hormonal fluctuations associated with, the progesterone, estrogen, testosterone induced triggers of acne, because it increases oil gland production, sebaceous gland production. So if you're kind of blocking that, propagation, you're essentially controlling their acne. So yeah, cultural kind of like roadblocks, right? But then you have the conversation, you reassure. And then you talk about, the effects, the psychological benefits it can have. Like, do you want a child that you're trying to talk about not, engaging in sexual activity, or do you want someone that's that's thriving and not suicidal and not having self-esteem issues and can kind of thrive, so it can be, different approaches too. And I'm glad you said that, because a lot of dermatology, especially pediatric dermatology, you're kind of treating the parents, like you're kind of appeasing fears and educating them as well about how it feels to have this condition and what they're, how to help them make, because they're ultimately the decision makers, right? They're the ones making the medical decision, which appropriately so. So you're also educating them so they can make the best decision for their children.
Yeah, and they're protective of their children. They want the best for them.
Exactly.
So Brother Kayode Ajayi Smith here said, Dr. Olowoyeye, is your lovely face a product of your diet or meds or both? If it is, what does your diet look like?
I'm very flattered. Thank you very much. I, like most people, struggle with everything. So I always say I'm the dermatologist that has all the dermatologic issues. So I have been, since I was a teenager, acne prone. Luckily, not severe acne prone, but I've been on topical retinoids most of my life. And I try to be not a bad patient as a doctor and have, the well-rounded diet with, walking 3 times a week, I try to, air off on the Mediterranean diet, because there's a lot of studies that prove that's a very healthy diet, lots of water. And yes, I have a very complex skincare regimen. If you come to my office, we'll talk about it.
Fantastic. So, this is my sister, Master Kenny Ayodele said, what do they mean someone's skin is stressed? Can your skin be stressed?
I don't understand the context. I've never heard of that term. I'm sorry.
Me neither.
Skin stressed.
Can you come up to explain what you mean by that? But that the skin is stressed. The only thing that I think can stress skin, or maybe not the only thing, but maybe one thing that can is the sun. Without sunscreen.
Yeah, and
when you get sunburned.
I mean, I can talk about that a little bit. People like to say black don't crack. Well, eventually it does because of the sun, and it folds. So we don't tend to wrinkle, we tend to fold. So you want to definitely wear the sunscreen and, practice good skin hygiene to kind of prevent, if you're worried about anti-aging. But yes, you see stress from wrinkles. You can still see stress from post-inflammatory hyperpigmentation in skin of color. So, I always say you breathe on skin of color and it turns dark, in a spot, and so, and maybe we could talk about that, in future talks about pigmentation and skin lightening and all this stuff. But you can see stress with wrinkles, and you can get dark under eyes from not sleeping well. That usually is a product of maturity, not sleeping well, and skin turgor as well. So yeah,
I like that skin lightening one.
yeah,
This is the skin for sure.
That's a big topic.
That's a big one,
especially in our culture.
Yeah.
Yeah. We'll save that for later.
yes, because that's another big topic.
Yeah.
So Dr. Ajagbe asked if you have experience with Neomedrol and what's the efficacy?
Neomedrol, I'm gonna have to look that one up. Is it like a oral steroid?
It seemed like that. It's a Medrol, so it's a steroid for sure.
Okay.
But it's NEOP, Neomedrol?
That's not one that we use here, at least I'm familiar with. But in general, oral steroids are commonly used in atopic dermatitis, although I try not to, because usually we know that there's a rebound flare that happens once you taper off of oral steroids. So if we do use it, it's for moderate to severe cases where there's cases of acute infection and widespread involvement, and you're buying time for topicals to take over. So, yes, I have experience with oral steroid use when it's for very, very severe cases, when we need a little bit more time so that things can balance out a little bit with getting topicals on board, emollients, reducing the amount of bacteria on the skin, all the things I talked about.
Fantastic. For me, in my space, if I feel I have to use steroid on a patient for any disease entity for more than 5 to 7 days, they go to the specialist. I don't want to deal with it.
Exactly. And if you're going to have to deal, if you ever are in a situation where you do use steroids,
oral steroids, yeah.
Well, oral steroids, I would actually opt for intramuscular. I would just, 80 milligrams in the buttocks. And why is because, when it's intramuscular or adipose tissue, it kind of has a slow release over time. So like 80 milligrams of like prednisone, what do we use? Prednisone?
No.
We use
prednisone.
We do prednisone, like 80
prednisone,
milligrams is almost like having like about 5 milligrams released per day. So it's like, instead of dealing with the compliance of patients taking oral, you can just give them IM. So I like that because it buys me about 6 weeks for us to like do everything we need to do.
Don't worry, I'll send them to you.
Yeah, please do, please do. It gets really complicated, but the most important thing is that, we start with the, on the primary care kind of level, we start with the topicals, we start with the moisturizing, we start with like the antimicrobial, and 9 times out of 10, that's good enough, because most eczema is mild eczema actually, but it's those moderate to severe patients that will have like the weeping, the widespread involvement, the itching and the scratching, the lack of sleep, and the widespread involvement that we then take over. And again, biologics have been a game changer. It's just exciting to see as a young dermatologist, these new medications, how, compared to like cyclosporin, methotrexate, these nephrotoxic medications, that affect the liver as well, how you can just immune, modulate and target these like interleukins and really stop the progression of the inflammatory cascade. It's amazing. It's an injection, some of them are mostly injections, but it's a game changer.
Fantastic. Dr. Famuyiwa, kindly unmute. She has her hand raised.
Hello.
Hi.
Thank you. Quick question. Do you have any opinion about benzoyl peroxide?
Yes. Yeah, that's a great question. Benzoyl peroxide is amazing for papular, pustular. Are you in the context of atopic dermatitis or eczema?
You sort of got into it a little sideways because I told my daughter not to use aluminum containing deodorants. So
Right.
she goes, I researched it. I think I'll use benzoyl peroxide
Oh
wash
yeah.
instead.
Oh yeah, benzoyl peroxide or glycolic acid are great alternatives for deodorant.
Aluminum based.
Yeah, removing aluminum from your skincare regimen. So what you do is you kind of basically hyperhidrosis or excess sweating is and then the odor that occurs subsequently is multifactorial. It's first you have the excess sweat, and then you have the bacteria that propagates from the excess sweat, and then that then causes odor. So if you use something like glycolic acid or benzoyl peroxide to kill the bacteria, then you're essentially decreasing any odor from occurring. You're not really preventing extra sweat, but at least you're not having the odor. So it's a natural, great alternative. And for patients, for deodorants, and for patients who want to still have a little odor afterwards, then I like clindamycin swabs in combination with like benzoyl peroxide to help with that. And then they're set.
Thank you.
You're welcome.
Thank you. Dr. Buka, you can unmute.
Thank you. Thank you. It was quite inspiring. Even though I love dermatology as a medical student, I shied away from it. I thank you for all the information today. Because in Nigeria, in the 70s, most of our dermatology was leprosy. They never got better, and they always keep coming back, and they never got better. So that was the main thing at our dermatology clinic in Yaba. Mm-hmm. But what I was wondering is psoriasis. Is it a form of eczema or is it completely different? That was my question. Mm-hmm.
Oh, that's a great question. So psoriasis is completely different category of like what we call papulosquamous dermatitis. It's a completely different pathway where you have with eczema, you have a break in the barrier of the epidermis and all of those different inflammatory response that happens afterwards. But with psoriasis, you have an extra propagation of the epithelial lining. So you have more hyperkeratosis. So that hyperkeratosis, thickening of the skin, instead of having, like, theoretically, right, if you have like 5 layers of epidermis, with psoriasis, you have like 100, so it's like a hyperkeratotic condition. And then you do have inflammatory responses that happen in a different pathway for that. So then the biologics for psoriasis then target those individual inflammatory cascades. So different mechanism, different condition, and then also different biologic targets too.
But your biologics right now are very expensive. Are they trying to make it cheaper with the government?
Oh yes, welcome to the American politics. I live in Bethesda, and I always say that there's more lobbyists, as I have more lobbyists as neighbors than politicians. You would think most of the doctors and politicians that live in Bethesda, no, they're all lobbyists, and they're paid very well. So it's part of this pharmaceutical political environment we have to practice in as doctors. But I think our practice has a very good system where we really push. If a patient needs the medication, we go above and beyond and make sure they get it. I do a lot of peer-to-peer. I'll call up the medical directors and we'll just demand a peer-to-peer. But, we also know the stepwise approach that a lot of these insurance companies require to document that they failed this, they failed that. I just listened to a talk about biologics. Again, it's new and exciting in dermatology. And one of the clinical investigators, he said that, okay, yeah, they require us to use methotrexate. We know that methotrexate is nephrotoxic. I'll write a prescription and tell the patient, if it ends up in your system or in the toilet, it doesn't matter to me. I won't ask, so it's just, there's a lot of hoops that you have to jump through. We'll put patients through the process, but yes, it's very expensive. Like, for example, Humira is at least $10,000 a month, cash, just cash, not with insurance incentives and things like that. But we do know they work, and they're the future. Targeted treatment, immunotherapy, biologic therapy is the future of medicine, even in the future of dermatology, nephrology, and rheumatology, and also oncology. We used to go from like 2-year survival for metastatic melanoma to now 5 to 7 years with immune directed therapy. So they're costly, but they're very effective. And as physicians, we have to advocate for our patients.
Wow. We have a lot of work to do in medicine.
Yeah.
In order to, do better for our patients. Because right now, sometimes it seems like we're just helpless. Mm-hmm. We are at the mercy of insurance companies and people who never practiced medicine making decisions.
Right.
Something will change though. So, Brother Kayode Ajayi Smith asked also if you have heard about sea salt for scrubbing the face. What are the benefits or dangers of that? But there's another statement here that you may want to link to that. Ayat Abe says, swimming in the Dead Sea, that's high salt times 8 potency at more than regular sea salt level. Cleared his eczema for months. Any thoughts? I think they go hand in hand.
Yeah, I've never heard of sea salt scrubbing, but I've heard of micro exfoliants for the face and the body, which we know can cause tiny little tears in the epidermis. So we used to like the apricot facial scrubs and those like really like rough, gritty facial scrubs, but now we kind of now do micro exfoliants, and we use, and we now know that there's bad for the for the coral reef, so we don't use that anymore. But we can use micro exfoliants. Sometimes they're made out of like crushed seashells or things like that. And I don't recommend exfoliating either with a loofah or micro exfoliants or chemical exfoliants like alpha hydroxy acids or beta hydroxy acids for no more than 1 to 2 times a week, because any more is very irritating to this epidermal barrier of the skin. And in terms of like swimming in the Dead Sea, I'm pretty sure that's more to address, you probably had more bacterial induced eczema. So, swimming in the Dead Sea probably was antimicrobial, just like how a lot of my patients do really well in the summer because they're swimmers and they're in that pool water all the time. It probably was antimicrobial and also a little exfoliating for you. So
Nice. Thank you.
I always say, if it ain't broke, don't fix it. That's my motto in in dermatology. If because there's a lot of it's very personalized, and dermatology can be very personalized. What may work for one person may not work for the other, but if it ain't broke, don't fix it. So if it works for you, you just keep doing it.
Thank you so much. Sister Wume Kamsen, also from California, has a question for you.
Hi.
Welcome.
Good evening, everybody. Thank you so much for the presentation. Awesome. I mean, thank you. So my question is about the, it's called dermatosis papulosa nigra. That's the Morgan Freeman skin issue, because I'm starting to have it a little bit here and there. What is the cause and what is the treatment for it? I mean, is there a treatment for it?
So
okay, before you answer, I wanted to say this. There are, we're a mixture in our population here on Medical Mondays with Dr. O. So you've been addressing us. I keep smiling like everyone is.
Like they're all doctors,
that we're all doctors. No, there are lots of people on this platform that are not doctors. We have lawyers, we have counselors, we have accountants, all walks of life. So it's been fun though. They are phenomenally smart, everyone on this forum. So I know they get it. And if they didn't get it, they would have, hit you up in the chat box or raise their hand. So you good. Yeah,
okay. So dermatosis papulosa nigra is DPN for short. So you just put DPN into Google and you'll get the entire name. I call it, like she mentioned, the Morgan Freeman disease or condition. It's basically benign growths of what I like to say maturity and genetics. We don't like the A word in dermatology. We like the M word, which is maturity. We all can hope to be as mature as possible. And so when you kind of hit a certain sweet spot, your genetics starts kind of triggering and you start getting these benign growths that are genetically linked on the face, neck, or shoulders. They're 100% benign. And so what I like to do in clinic is to bring you in. It's a cosmetic appointment because insurance will not cover it. And we'll numb the face for about 20 minutes and we'll use a tiny little heat tool. I don't like laser treatment because then you have more post-inflammatory hyperpigmentation or dark spots on the face. So it's a pinpoint heating tool that will burn each individual spot, and it's above the layer of the epidermis, so it's more water content. So let's just say it's about 75% water. So when you use a heating tool, it coagulates it and crusts it up. And so what happens is that over the course of 2 weeks, the crust falls off and you're left with smooth skin. Now, it can be white or dark. I always say you're trading a black or dark bump for a flat, dark or white normal skin. It could be a scar, a tiny scar, but with sunscreen, it should normalize so you have your skin.
Okay.
So you want somebody that treats DPNs with cautery is what you want to ask for.
VPN recovery. So,
Yeah.
but do you know what causes it? How come some people have it and some people don't? Is it just genetics?
Genetics, and then you hit a certain maturity spot, and then you start getting it. But you usually can link it to one of your parents that have it, so.
Which is interesting. My mom doesn't have it, and I don't really have anybody in my family that I think has it, but it's okay. I mean, that's fine. But thank you.
It's 100% benign. So luckily, we know it doesn't become skin cancer. They just can be cosmetically annoying. And they covered all the face of Morgan Freeman. He's just accepted.
He's like, forget it. I'm not dealing. I don't care.
Yeah, but I did have a patient who was very she said she was teased. She was like one of 5 daughters, and she was the only one that had it. And she was determined. So from like October to January, every 2 weeks we would, and you can't do too much at a time because pain threshold, and also scarring, and also wound care and infection control. So you don't want to open too much skin. But she was determined, and now she feels her skin. Now everything is smooth, so it's great treatment for it.
All right. Thank you so much. I appreciate it.
Well, you can always come to Maryland. Come hang out and come get your
I know, right? I'll come hang out with you.
No, yes, insurance company will not cover it anyway, so it's cosmetic.
Yeah, make it a trip.
Okay, all right. Ask and you shall receive.
My best friend flies in from California to get her Botox and her filler. So why not you?
Okay, all right. Okay,
see,
thank
I didn't even know that. So there's a comment here that regarding the sea water, back in the days, long ago, over 40 years now, in some part of Ghana, folks do swim in the Atlantic Ocean to improve their skin conditions or skin problems. So there's something to the water,
there's something
to the content of the salt.
Yeah.
So research would tell, or we can look it up and see.
And if you find it, I'll invest. I'll invest
Please.
in the product.
Yes. So I wanted to ask you about, the nail.
Mm-hmm.
I see a lot of these longitudinal melanocytes, melanocytic lines. Is that what you call it?
Longitudinal melanonychia.
Melanonychia, the longitudinal melanonychia in Black folks.
Mm-hmm.
And sometimes they come to clinic and they're worried about it, but it's like in almost all their nails, usually in the hands, it could be in the feet. So what do you think of that? Does it need biopsy?
It definitely needs a referral to a dermatologist, just because we see it more often, and we're trained to decipher what can be concerning versus not. I personally use a dermatoscope, which is a magnifying scope that we were trained in, to measure and also look at the pigment network. So usually with longitudinal melanonychia is just like normal variant of pigment, just like how some people will have a darker lip, and some people might not. It's just normal variant hyperpigmentation. Now, the issue is that some forms of longitudinal melanonychia will change over time and evolve into melanomas. And so we look for something called the Hutchinson sign, which is changes or discoloration to the nail fold. So from the root of where the pigment is coming, if it's the pigment is starting to spread to the surrounding skin, that can be ominous. If it's also widening, then you may want to do a nail biopsy. The issue with jumping to a nail biopsy is that it will cause permanent nail dystrophy. So it can split the nail, or it can cause the nail not to ever grow back. So you really want to do the nail biopsy when you're really sure that something is concerning or changing over time. So I personally feel like all longitudinal melanonychia should be evaluated by a dermatologist, because you should be getting your skin check anyways. When you're there, they can just look at your nails.
Fantastic. Okay. Thank you so much. That is invaluable. Trust me. So Dr. Fawale said, well, let me just say, you said you have not done a presentation like this in a long time. You've gotten a lot of comments, people thanking you, appreciating this presentation, that it's fantastic. If we have time, I'll go over that really quickly. But she says, what is your position on using facial treatments to remove blackheads or using cosmetics to cover them?
So it depends on the context. I think if a patient has comedonal acne, which is acne, blackhead, whitehead, predominant acne, I usually try to use medications first to chemically, what we call chemically exfoliate. So retinoids are great for that. There are stubborn, deep blackheads though that are just persistent, and a lot of these, I call them young TikTokers. They're just very fixated on their face, and they have like these 10x mirrors, they see everything. So if anyone is concerned about blackheads, then I love Biore strips. I love micro exfoliants, and any kind of like glycolic acid, for example. But again, it's not exfoliating no more than once or twice a week is the maximum. I wouldn't do it more than that because it can just over irritate the skin.
Thank you. So Ayat said again that at the Dead Sea, there were several patients from the EU with prescriptions or referrals from their doctors, but that his doctor here in New York told him, we don't write such referrals in America. Well, he asked for a prescription to return to Dead Sea.
Interesting.
Ayat, please unmute and tell us why a prescription is needed. Because is this in Israel? I have been to Israel and I don't know why a prescription will be needed for that Dead Sea thing if it's Israel. Kindly unmute and educate us.
The prescription was only a way to get out of work.
I love it.
That would be the only logical way to leave work and go back.
I love it.
But yes, there were several patients from all over the EU with eczema, what's the other, psoriasis, and several other dermatological disorders. And they all had prescriptions, and they come there yearly, 3 months to 6 months. And and when I told my physician, he says, well, we don't do that in America. So the prescription really was just a way to have my time out of work and go back there and heal. I've had eczema since I was a baby, so but I've also learned over the years that I can manage it without sugar. Sugar is a huge trigger, or any starchy foods. So that's how I've learned to manage it. But otherwise, in my past life, lots of steroids, topical steroids were used, which were, I think, maybe my parents were ill-advised. If they had talked to them about food allergies, maybe,
Exactly.
But I also have on that note, I had a patient who was treated with honey. This patient had a chronic wound for 2 years, and it was due to eczema. When she saw a dermatologist, he says, your body that wound needs honey. And as soon as the honey treatment started, in 1 week, the wound started. This is, mind you, 2 years ongoing. In a week, the wound started closing and she was ready to return to Portugal.
Right.
So I don't know what the relationship is between the eczema she had, and honey.
So
sugar.
It's interesting you brought that up, because I've guess I've lived many educational lives. But prior to dermatology, I did 2 years of wound care. So I was a wound fellow at Johns Hopkins. And so we saw a lot of different chronic wounds, venous leg ulcers, pyogenic granuloma. It was Baltimore, so a lot of like decubitus ulcers. And so there is a role for medical honey, actually. It's there's a product called Medi Honey that it's basically bioengineered honey that you know, probably on an alginate kind of gauze pad that we apply to chronic wounds. And honey is known to be antimicrobial. So I probably no doubt that, you know, again, more bacteria, predominant eczema, healed with, you know, treating the microbial component of it. It also has healing properties. It's an emollient, so it's almost like Vaseline in a sense that it acts as an emollient as well, like to lubricate skin. We know that wounds heal better once it's lubricated and when it's a nice balance between wet and dry. You don't want a wound too dry, and you don't want a wound weeping and oozing either. So you want a nice homeostasis. So there's actually like medical honey actually now. It's called Medi Honey that you can purchase for wound healing.
Wow. Wow. Thank you.
Yeah, that is true. We recommend that. I
Thank
don't
you.
like wound care, but anti-towel. I give you kudos that you did that. It's one of my no good.
Yeah, I just want to contribute to that Depsy. I think it's because of the clay. I swam in it, and I think it's, you know, it's like a quicksand. It's so gooey and it's like a clay. I think maybe that is what is helping there.
Yeah, that's just so interesting. I mean, it's interesting that there's so many comments about it. I think there's definitely something there. And wouldn't it be amazing if there could be some research about the medicinal aspects? So we all have like our own family recipes brought down in terms of like, you know, like this baby is sick, then you have grandma like making her paste in the backyard, you know, and at least that's how I grew up. And even to this day, I use my grandma's recipe of aboliki and all this other stuff. You put it into the pot. And so it's just, I mean, it would be so interesting if you take all of those like traditional practices and you actually do some research into, you know, why it works and help other people out. It's amazing. Yeah.
So, Auntie Lara, this is Madam CEO from California of NAPAC, that's the Nigerian American Public Affairs Committee.
Okay.
Said you should come back because she said, Dr. Omolara, thank you for a great discussion. See you next time. She's telling you that she'll see you next time again. Sister Clementina says, thank you for a thorough presentation. She's in healthcare too. She's an NP.
Okay.
She said, our wound care nurse at WR uses the biological engineered honey gauze, and it worked on our patient.
Oh, yeah.
Sister Tuka Baribo said, thanks, Dr. Omolara. She's a doctor. That was an awesome presentation. Okay. And I told you, I think Dr. Fawole, Ima says, your presentation has been interesting and informative, Dr. Olowoyeye. Thank you very much.
Thank you.
Dr. Fawole says, thanks for the comprehensive presentation. And I know that our attorney was the first, maybe one of the first ones to say, Drethel, sister or brother Drethel said, thank you, Dr. Olowoyeye. Excellent and very informative. My brother, Mr. Taye Doherty, said, great presentation, Dr. Olowoyeye. Attorney Richard Williams said, excellent presentation. Thank you, Dr. Olowoyeye. And Mary, that's another healthcare professional, says it was a great presentation. Thank you.
Thank you.
And, the list goes on. I'm missing some new chats. Oh, so Varidara, how are you, darling? Oh, she's at Harvard. And, I'm so glad she's on this presentation. I'm sure she'll give me excellent feedback. She says, thank you so much, Dr. Omolara, for an informative presentation. We appreciate you.
Thank you.
And so before you give us, a summary of all of this, no, let me say not summary, you already gave that, take home message. I just wanted to alert you to the fact that there are some old faces that on this platform, and they are, apart from God, the backbones of Medical Mondays with Dr. O. AJ, does that name sound familiar to you? AJ, IT. Ephraim. AJ. It does IT work, sets up your computers and stuff like that.
Yes. Yes.
Congratulations.
Thank you. Yes.
So I don't know if you know,
Dr.
camera, please.
Oh yes, somebody
Unmute your camera for her again. So I don't know if you know, he's a pastor, he's a doctor, and so is his wife, but they will never tell you. They never introduce themselves. I tell on everybody because I'm so proud of these accomplishments that people don't want to talk about.
That's great.
So they say big contracts.
Thank you.
Congrats.
It was Dr. Kindred that linked us up.
Yes. They told me that she did. She's been on Medical Mondays with Dr. O.
Oh, she?
Also.
Okay,
Yeah,
great.
she has. So Anna and Ephraim said, big congrats, you are going far.
Thank you.
And Rhoda Coyote said, awesome presentation. Thank you. So if you now give us, a take-home message that we can take home.
Well, I think that skincare is a very important part of your overall care. I think that, it being like the first presentation to who you are, your money maker is what I call it. We want to take care of that as well. I think that, there's a lot of conditions that we see that we I think culturally we try to think that it's cosmetic, but it's actually medical. And I think there are great physicians out there that are ready to align with you and your patients and your loved ones to really address any issues that may arise. I think that we should, continue to take care of ourselves, and, the skin is just one of those factors. And thank you so much for having me. I learned a lot. I've been kind of a silent observer for a couple of talks too. I've got all of my financial and my life planning, estate planning to-do lists from the previous talks. I think this is a great platform. It's great for people like me that are more introverted to come out of their shells and be introduced to different people and really network, because that's really what it's about. If anything that the pandemic has taught us is that we only have each other. And it's really great to have a community of like-minded individuals that share like-minded goals. And I look forward to being a part of it.
Thank you so much. You are already a part of it. Thank you so much. And I'm going to make my appointment to see you for my full body exam.
Wonderful.
Because I need one. And It's very interesting. We all honest about things on this platform. I never knew that we needed one unless there is an issue. And that was why I asked that specific question. So I learned something, and I'm going to be the first to do that. I have to have my whole body checked. So I'll make my appointment.
Wonderful.
Thank you so very much. This has been
for having me.
Fantastic. Thank you. And oh, wow. We can't wait to see you for the next one.
That's great.
Thank you. So again, we don't establish physician-patient relationship on this platform. We share important information to prevent disease entities or maybe to help in treatment without establishing care. However, if you would like to see Dr. Omolara Olowoyeye, I've been reposting her practice information over and over throughout the evening. She's at Radiance Dermatology, 10215 Fernwood Road, Suite 414, Bethesda, Maryland, 20817. And she,
I forgot to call.
just 1 second. Let me mute my brother real quick. So, her phone number, which is maybe the most important thing that you want to know, because once you call the number, they'll give you the address, is 301-430-4000. And believe it or not, one of my uncles who raised me is on the platform. And Brother Juby, this is very interesting presentation. Thank you.
Yeah.
Thank you, sir.
Thank you very much.
Welcome, sir. And Sister Bella says, thank you. Awesome presentation. I'm sorry, I'm always excited about this, appreciation. These are genuine people. If they don't know, they don't mean it, they won't say it. So thank you so much, AJ. He has posted the link for the address, so you can just click on that in the chat box, and you can, find where Dr. Olowoyeye is. And I want to encourage us to stay safe, because COVID is still out there. I got my behind kicked, and I'm the one who wants everybody, but I party too much. So stay safe. There's COVID, there's RSV, there's monkeypox now, and there's flu still in season. So we still need to be careful, wear your mask until we see next week.